Hello and welcome. I'm Fernando, a GP in the UK. Today we're doing a review of the NICE guideline on CKD or NG203, focusing on what is relevant in primary care only. Given how extensive the guidance is, in this episode I will just focus on diagnosis and classification of CKD. In the next two episodes, I will cover investigations, monitoring, referral recommendations, and CKD management in primary care. So stay tuned for those. Right, let's jump into it. For this review, I have excluded recommendations related to children and young people with CKD. While their management is often similar to that of adults, most children with CKD are managed by secondary care, and this is why I am focusing on adults. Let's review the investigations recommended in CKD. CKD can be classified depending on the levels of renal function and the presence and degree of proteinuria. So let's have a look at renal function first. To assess kidney function, path labs should report a creatinine-based estimate of glomerular filtration rate or eGFR creatinine alongside the serum creatinine result. For simplicity, from now on I'll refer to eGFR creatinine simply as eGFR. Because of how eGFR is calculated, eGFR results may be less reliable in certain situations when we should interpret it with caution. Examples are AKI because of the acute fluctuations in eGFR, edematous where eGFR could be both over or underestimated depending on the case, pregnancy because it is associated with a physiologically increased kidney filtration rate, muscle wasting disorders, amputation, and in malnourishment because reduced muscle mass can lead to an overestimated higher eGFR, and those who have higher muscle mass or use protein supplements because conversely they can have an underestimated lower eGFR. It is also for this reason that we should advise patients not to eat any meat in the 12 hours before having the blood test. Although eGFR has not been well validated in certain ethnic groups, like Black, Asian, and other minority ethnic groups in the UK, NICE has removed a previous recommendation of adjusting eGFR for specific ethnicities. Also, because of lack of evidence, NICE no longer recommends measuring eGFR using cystatin C. Path labs will report eGFR either as greater than 90 or as a whole number if it is 90 or less. If renal function is suspected to be impaired despite an eGFR greater than 90, a significant reduction in kidney function can be inferred if serum creatinine increases by more than 20%. We also need to remember that eGFR becomes less accurate as the true GFR increases, so we should interpret eGFR values of 60 or more with caution. If we have an eGFR less than 60 in someone not previously tested, we will confirm it by repeating the test within 2 weeks. When interpreting changes in eGFR, we will allow for a natural variability of 5% in serum creatinine levels. This range reflects both the biological fluctuations and the variability of the test in practice. Let's now look at investigations for proteinuria. For the initial detection of proteinuria, we will not use reagent strips unless they are capable of specifically measuring albumin at low concentrations and expressing the results as an albumin-creatinine ratio or ACR. If sending the urine to the path lab, we will request urine ACR rather than protein creatinine ratio or PCR because of the greater sensitivity for low levels of proteinuria. And if the ACR is between 3 and 70, we will confirm it in a subsequent early morning sample. This is because the concentration of protein in the urine can fluctuate throughout the day due to physical activity, posture, and hydration, which makes early morning samples a more consistent and reliable measure. However, a repeat sample is not needed if the initial ACR is 70 or more. We will regard a confirmed ACR of 3 or more as clinically important proteinuria. Should we routinely screen for ACR? Well, we should check urine ACR in the following groups: diabetes, either type 1 or type 2, eGFR less than 60, eGFR of 60 or more if there's a strong suspicion of CKD, and children and young people with creatinine above the upper limit of normal. When ACR is 70 or more, PCR can be used as an alternative to ACR. Earlier, we mentioned that reagent strips should not be routinely used to test for proteinuria. However, they are routinely used in practice. So what do we do if we detect proteinuria or non-visible hematuria on the strip? Let's have a look at these scenarios. If unexplained proteinuria is an incidental finding on a reagent strip, we will offer testing for CKD using eGFR and ACR. Unlike proteinuria, for hematuria we should use reagent strips, and we will investigate further for results of 1+ or higher. But we are specifically advised not to use urine microscopy to confirm a positive result, as urine microscopy would not detect hemolyzed hematuria. How do we manage isolated invisible hematuria? If you haven't already, I recommend checking the episode on non-visible hematuria on this channel. The link to it is in the episode description. But in summary, to differentiate persistent non-visible hematuria without proteinuria from transient hematuria, 2 positive results out of 3 reagent strip tests are considered confirmation of persistent invisible hematuria. Persistent invisible hematuria with or without proteinuria should prompt investigation for urinary tract malignancy in appropriate age groups. For persistent non-visible hematuria without proteinuria, annual follow-up is recommended with repeat testing for hematuria, proteinuria, eGFR, and blood pressure monitoring, as long as the hematuria persists. Who should be tested for CKD? We will check eGFR and ACR if there is diabetes, hypertension, previous episode of acute kidney injury, cardiovascular disease, structural renal tract disease, recurrent renal calculi or prostatic hypertrophy, multi-system diseases with potential kidney involvement, for example SLE, gout, family history of end-stage renal disease or hereditary kidney disease, and incidental detection of hematuria or proteinuria. Additionally, we will monitor eGFR at least annually in people on medicines that can affect kidney function, for example, lithium or long-term chronic use of non-steroidal anti-inflammatory drugs. Also, we should monitor people for CKD for at least 3 years after acute kidney injury, or longer for people with acute kidney injury stage 3, even if eGFR has returned to normal. Once CKD has been detected, we will need to classify it using a combination of GFR and ACR categories. The ACR categories are A1, A2, and A3, where A1 is when the ACR is less than 3, A2 is when the ACR is 3 to 30, and A3 is when the ACR is over 30. The GFR categories are G1 to G5, whereas G1 is when the eGFR is 90 or over, G2 is when the eGFR is 60 to 89, G3A is when the eGFR is 45 to 59, G3B is when the eGFR is 30 to 44, G4 is when the eGFR is 15 to 29, and G5 is when the eGFR is under 15. We need to be aware that an increased ACR and decreased eGFR is associated with increased risk of adverse outcomes, and that an increased ACR and decreased GFR in combination multiply this risk even further. So that is it, a review of the diagnosis and classification of CKD. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.